Hello everyone, welcome back to the continuation of question paper discussion and pediatric dentistry. We are into the sixth part of our question paper sessions. So this session is about cariology, caries management and various caries detection tools. So the most commonly asked question was about early childhood caries. Describe the stages of ACC and management and differentiate between nursing bottle caries and rampant caries. So let's see the definition of our early childhood caries. So it is the presence of one or more decade. It could be a non-cavitated or cavitated one, missing or filled tooth on any primary teeth in a child that is 71 months of age or younger. 71 means almost 6 years. If the child is under 3 years of age, that is children younger than 3 years of age, if any sign of smooth surface caries which is indicating of severe early childhood caries. This is childhood caries. Early childhood caries was talking about 71 months, almost 6 years or younger, but this is 3 years of age. That is known as severe ECC. From age 3 to 5, one or more cavity, these are the criteria. If it is age 3 to 5, one or more cavity, missing or filled surface in primary maxillary anterior teeth, or a decade, missing or filled score more than 4 in number for age 3, more than 5 in number for age 4, and more than 6 for age 5. That all constitute as severe ECC. Okay. So what could be the etiology? It is very simple one, that is poor oral hygiene, insufficient fluoride and decay causing bacteria. Oral hygiene, as we all know, if oral hygiene is not there, it is directly linked to plaque accumulation, and over the plaque we will be having bacteria and there will be production of acid and tooth demineralization, which is tooth decay. And fluoride, insufficient fluoride. Fluoride is naturally occurring mineral which is found to be preventing tooth decay. So these fluoride sources include toothpaste, mouth rinse, normal tap water, all can prevent dental caries to an extent. So if you don't have sufficient amount of fluoride, there will be chances of caries. And the presence of bacteria. That is, many bacteria work together to cause tooth decay, but certain bacteria play key role, like Streptococcus mutans, that is smooth surface caries, and Lactobacillus causes deep surface caries, deep caries. That was about etiology of early childhood caries. Now the stages of ECC, that is, it is starting as initial, reversible, then damaged caries stage, then deep lesion and traumatic stage. In initial stage, it is like chalky white discoloration along the gum line, and there will be plaque, and it is reversible. If you do proper oral hygiene and remineralizing agent, we can reverse it. The next step is, or next stage is, damaged caries stage. That is, this chalky white is becoming yellowish brown discoloration with cavity, and dentine is also involved. It could be asymptomatic or sensitive to cold. Whereas the next stage is more advanced, that is deep lesion, which is present on molars and incisors. It is involving pulp. It could be painful, sometimes asymptomatic, and last stage is traumatic. Tooth is already gone, the structure is gone. Fracture and minor trauma will lead to loss of crown structure, and maxillary incisors are non-vital. Pulpal involvement is there. Pain may or may not be present. Next we have prevention. So how do we prevent ACC? So we have various methods. First one is using a chlorhexidine varnish, then do a proper dietary counseling, And early detection is a vital thing in prevention of ECC. When we have a detection or a screening before the age of 1, that will be very vital. We can give fluoride supplements, fluoride dentifrices, prenatal fluoride supplements, water fluoridation, and control of mother-infant infection with cariogenic bacteria. All can be applied as preventive strategies. So how do we manage it? So this is a basic flow chart of managing ECC. You can just pause it here and see what are the steps. So initial or recall visit, how do we include it, then how do we manage it. We have caries risk assessment, then clinical examination, caries charting, and self-management goals. So all are there. That disease management visit from 1 to 3 months, 3 to 6 months, and 6 to 12 months, all are there. So basic thing is we need to do caries risk assessment. We need to take radiographs. We can start with topical fluoride in the initial visit. So we need to have a good support from the patient also. So we need to explain caries process and causes of ECC. So proper communication is very important in management of ECC. So you can just draw this flow chart when you have the question of ECC management, not explaining it because it's all self-explanatory. So what is the difference between nursing caries and rampant caries? Very commonly asked question, and it's very easy one, but it is still a confusing one for many of the students. They write opposite answers for nursing caries and rampant caries. So the first thing you need to understand is nursing caries is a specific form of rampant caries, because rampant caries is a bigger one. So nursing caries is a type of rampant caries. Okay. So rampant caries, it is acute widespread caries with early pulpal involvement, which are usually immune to decay. So in which age group it is seen? Nursing caries seen in infants and toddlers and basically affects primary dentition, whereas rampant caries seen at all age, adolescents, and affects both primary and permanent dentition. Okay, so rampant caries is a bigger classification, and one of the type is nursing caries. So in nursing caries, mandibular incisors are not involved, but in rampant caries, that is also affected. Etiology, nursing caries, basically it is bottle feeding before sleeping or applying pacifiers or prolonged breastfeeding. Whereas rampant caries, the etiology could be multifactorial, bottle factors, frequent snacking, excessive sticky, carbohydrate intake, decreased salivary flow, or genetic background. Now we have the same question being repeated. ECC, describe in detail about etiology and management. And next question, same question, but clinical features are there, and again management. Next we have question that is diet counseling and its role in prevention of dental caries. That is, diet plays a central role in development of dental caries because it is both same time host factor and agent factor. So it is clearly shown that relationship between frequent consumption of carbohydrates and caries activity. There is a strong evidence, there is a causal relationship between frequent snacking and caries activity. So if we can modify the diet factor, we can control the caries. So the local effects of diet on plaque metabolism and specifically on acid production are considered to be far more important for caries development than the systemic effect of tooth development and saliva components. So caries is basically depend on diet. So if we manage diet well, we can prevent majority of the caries rather than the other factors such as saliva and tooth development. So how do we conduct counseling? dietary analysis. A vigorous and comprehensive program of dietary counseling is reserved for those few patients for which such is required, that is, children with extremely high caries susceptibility, those with numerous caries lesions affecting both features and small surfaces, or children with history of caries who are beginning full banded orthodontic care, or children who for whatever reason are unable to maintain a relatively plague-free oral environment. So these are the basic people who should be getting dietary counseling. And when a comprehensive dietary consultation is to be accomplished, the parent is asked to keep a diary of the child's food intake for 5 days. Then it is evaluated with the parent to demonstrate all of the exposures to refined carbohydrate the child has received and to suggest the alternatives. So diary keeping is very must, and it should be with the parent. So most parents are surprised at the frequency and degree of the child's intake of fermentable carbohydrate. So these are the method, that is 24 hours diet recall, recalling the food and drinks consumed the last 24 hours. The advantage is it does not alter food intake pattern, it can be easily remembered, but the problem is we need to have trained interviewer. There is chance of recall bias. The patient might not properly recollect what he or she had taken in the last 24 hours. It is not actually representative of the patient's routine dietary intake. It could be on a festival day, the patient might have taken more sweets or more other carbohydrate food, which is not, or which is contradicting its usual pattern. So next we can use a food frequency questionnaire. It is easy to administer, does not change the usual food intake, but again recall bias. It is not open-ended, it is a closed-ended. Open-ended means the patient or the child has liberty to explain in detail, but this is not open-ended, this is a closed-ended, so he has to choose from the options given, and there is high chance of measurement error. And next one we have the dietary assessment. Also we have diet history. So all can be used to check the or do the dietary analysis, and based on that we can do the dietary counseling. Now we have the most important short test, that is caries detection tool. So we have visual tactile, that is a conventional method, then radiography, caries detecting dyes, fiber optic trans illumination, electronic caries monitor. So what are the ideal requirements of caries diagnostic aids and various diagnostic aids? Okay, so clinical method, on we know how to do it using explorer or sharp probe. Smooth surface lesion normally develop close to the gingival margin and are often covered in plaque. And on the buccal and lingual surfaces, optimal assessment is a visual appearance. You can just see the visual appearance. And on the fissures and approximal surfaces, it's more difficult visually, and we use indirect methods. And white spot lesion can be seen when enamel has been cleaned and dried. Okay, so that is a basic clinical method. Then we have the radiographic methods, that is a wide wing projection is the most useful. X-ray for detecting caries. Using X-ray we can we can see the presence of caries at very early stages. Always use a paralleling technique which increases the value of projection of detecting caries. So using size adult 2 size films for wide wing examination. So what are the dyes in caries detection? That is Procyon, calcium, brilliant blue are used for the enamel caries, dentin caries, basic xenon, methylene blue, and acid red. So modified dye preparation uses iodine. It measures the enamel porosity in incipient caries lesion, that is very beginning caries. So it's the white spot caries or white spot lesion. Caries is just started. And also use we can use potassium iodide. Diagnodent is an instrument by which we can detect caries, that is class 1, 5 and incisal lesion. Caries can be accurately measured. It is there will be visual examination and radiographs and transillumination aids is there. Intraoperative caries evaluation and helps in decision making to restore or not to restore. So, excellent caries management tool measuring the effectiveness of non-surgical caries treatment, that is remineralizing strategies. Now we have ECM, that is electronic caries measurement. Sound dental hard tissues shows very high electrical resistance, and demineralized enamel has lower resistance. So we can easily make out from this principle. And 40 is fiber optic trans illumination, uses light transmission through the tooth. So demineralized dental hard tissues scatter and absorb light more than the sound tissue. For enamel and dentine caries reduction on occlusal, proximal and smooth surface of anterior and posterior teeth, this can be used. So Dialex is one company or one fiber optic trans illumination from the Cavo company. So what is anticipatory guidance? So it is a step-by-step program taught by the dentist or dental professional in an office to caregivers and is tailored to each specific child. So it is a time-intensive procedure that includes but is not limited to examination, prophylaxis, diet analysis, home care instruction, supplemental fluoride, both topical and systemic and general feeding instruction. Okay, so what are the instructions? Try to stop night feeding once the teeth erupts. Use methods other than feeding to calm a crying child. If a child needs a bottle to fall asleep, it should contain plain water. Breastfeeding should be encouraged with good oral hygiene. Discourage ad libitum breast or bottle feeding. And for infants who continue to feed on demand at night, parents should wipe the teeth clean after feeding. So what is the difference between caries susceptibility and caries activity? Caries activity is the increment of active lesions. It could be new or recurrent over a period of time. Okay, so it is a measure of speed of progression. So how fast it is getting progressed, that is activity. Whereas caries susceptibility is the inherent tendency of the host and target tissue to be affected by the caries process. That is the difference. Now we have Miller's acidogenic theory. That is, Miller was the first well-known scientist and investigator of dental caries, and according to him, dental leak is a chemoparasitic process. That is, chemical is produced by the parasite, that is a bacteria. So two-stage process. There is decalcification of enamel, which also results in destruction of dentin. The second stage, there is dissolution of softened residue of the enamel and dentin. So there is a production of acid by the bacteria, and which causes dissolution and destruction. Rampant caries, we already discussed rampant caries. All this were discussed. So we know how it is affecting and the stages, how it is stage 1, stage 2, stage 3, all were discussed. Now we have the Snyder test in 1951. It is measuring the ability of salivary microorganism to form organic acid from a carbohydrate medium. So we use a bromocresol green indicator which changes the color of the solution based on the pH. When pH is 5.4, it is green. When the pH is 3.8, it is yellow. So if the indicator dye is not there, that is bromocresol green is not there, we will not be able to understand the change of pH. But when we put the dye, the color of the solution will be changed so that it is easily visible and measurable. So when the color change happens within 24 hours, there is high caries activity, that is marked caries activity. Within 2 days, that is 1 to 2 day, moderate. 2 to 3 days, that is slight caries. If nothing happens, no color change happens after 72 hours or 3 days, the person's saliva is negatively caries active. Sugar substitutes are substitutes which can be used to manage the problem of carbohydrate, and the carbohydrate are the positive thing for caries, so we can manage it by using sugar substitute. It is classified as nutritive and non-nutritive. Nutritive, we have rapid sweetness, sucrose, fructose, dextrose, and non-nutritive with alcohol and high intensity artificial ones. Sugar alcohols, xylitol, maltitol, sorbitol. The xylitol and sorbitol are commonly present in chewing gums. And these high intensity ones are sucralose, aspartame, saccharin, neotame. Window of infectivity is the age or the period at which the child is having high amount of bacteria. So it is between 19 and 33 months, during which most children acquire the cariogenic organism. So mother was the most common source of transmission of bacteria to the child. So factors affecting window of infectivity is high maternal infection, high dietary sucrose level. So children should be immunized before the window of infectivity. Okay. So that was all about the part 6. It was basically about the cariology, the early childhood caries, its clinical features, etiology, management, and we have many short notes like window of infectivity, sugar substitute, Snyder test, rampant caries, Miller's theory, caries activity and caries susceptibility, and anticipatory guidance, and the diagnostic aids like 4T, ECM, Diagnotin, dyes, radiograph, and clinical methods, and regarding the dietary counseling and the difference between nursing caries and rampant caries. So I'll come up with a part 7 in my next session, that is about restorative dentistry. Thank you.